Now, let's turn our attention to Jervell and Lange-Nielsen syndrome, or JLNS. This is a truly rare but clinically devastating condition that's often considered a more severe form of LQTS, isn't it?
It absolutely is. JLNS is a rare genetic disorder affecting only about 1 in 1 million individuals. So very rare. Its hallmark characteristic is the co-occurrence of congenital sensorineural hearing loss, meaning hearing loss present from birth due to an issue with the inner ear or nerve pathways and a markedly prolonged QTC interval on the ECG. The condition arises because an individual inherits two copies of a mutated gene, one from each parent, making it an autosomal recessive disorder. These specific mutations lead to a much more severe form of LQTS. Individuals with JLNS face a significantly elevated risk of life-threatening arrhythmias like torsades de pointe, and these often manifest very early in childhood.
So, what makes JLNS so severe and distinct compared to other forms of LQTS? What's going on at the genetic level that links the heart and hearing like that?
Right, the underlying problem in JLNS is a profound disruption of a specific electrical current in the heart, called the slow delayed rectifier potassium current. This is caused by mutations in both copies of certain genes, primarily KCNQ1 or KCNE1. Now, these genes are crucial not just for heart function, but also for the proper functioning of the inner ear's cochlear cells. In the inner ear, these electrical gates are vital for recycling potassium, which is essential for transmitting sound signals. When this process is impaired, it leads to profound hearing loss. And in the heart, the same faulty gates mean the heart cells take much longer to repolarize, leading to the extreme QTC prolongation we see. It's a double hit, affecting both systems. The clinical picture in JLNS is often quite serious and appears early. One study found that a striking 86% of individuals with JLNS develop symptoms, with 15% showing signs within their very first year of life. The vast majority indeed, most patients experience a major cardiac event, like a fainting spell, or even a cardiac arrest before they reached 18 years old. The most common triggers for these events are physical exercise and emotional stress. Swimming, as in our opening case, is a particularly frequent precipitant. It's also notable that very few events occur during rest or sleep for JLNS patients, unlike some other LQTS subtypes. Without appropriate intervention, the risk of mortality exceeds 50% by adolescents due to these life-threatening ventricular arrhythmias. It's incredibly serious.
How does the severe form specifically reflect on the ECG? Are there distinct markers unique to JLNS?
On the ECG, the key finding is a markedly prolonged QTC. We're talking about intervals typically exceeding 500 milliseconds that's significantly longer than what's often seen in the more common autosomal dominant forms of LQTS. The T-waves can also appear quite broad or notched, or even biphasic, with variations depending on the specific genetic mutation involved. Additionally, clinicians frequently observe bradycardia, or a slower than normal heart rate, which makes sense given the extended duration the ventricles need to repolarize. Beyond the ECG, audiometric testing consistently confirms a profound bilateral sensorineural hearing loss, which is of course a defining feature. You need that confirmation. And genetic testing is the definitive diagnostic tool, identifying those specific pathogenic mutations in the KCNQ1 or KCNE1 genes.
So how do doctors put all this together for a definitive diagnosis of JLNS? Is there a specific checklist for this one too?
Absolutely. The diagnosis of JLNS is established by a combination of key factors. A QTC interval that is consistently over 500 milliseconds, coupled with documented congenital bilateral sensorineural hearing loss. A family history that includes consanguinity, meaning the parents are related, or a sudden cardiac death, can also be a strong indicator. Finally, genetic confirmation of the specific KCNQ1 or KCNE1 mutations seals the diagnosis. It's interesting to note that the short score, which we mentioned for general LQTS, is less useful here because the presence of congenital deafness already provides a very strong diagnostic clue, points you strongly in that direction. It's important, though, to distinguish JLNS from other forms of LQTS, like Romano ward syndrome, which doesn't involve deafness. Clinicians also consider other genetic syndromes that might present with hearing loss, as well as acquired forms of QT prolongation to ensure an accurate diagnosis. Treatment for JLNS primarily focuses on reducing the risk of arrhythmias and, crucially, improving the patient's quality of life. Beta blockers, such as propranolol and nadolol, are the first-line therapy because they help reduce the heart's excitability. For patients at high risk, particularly those with a history of cardiac arrest or recurrent fainting, an implantable cardioverter defibrillator, or ICD, is usually recommended. A truly vital aspect of management for JLNS patients is the use of cochlear implants. These can significantly restore auditory function and improve communication, which is huge for quality of life. Additionally, lifestyle modifications like avoiding medications known to prolong the QT interval and minimizing stressful stimuli are essential. While the prognosis without treatment is guarded due to the high risk of sudden death, timely and appropriate interventions can dramatically reduce mortality and improve long-term outcomes.